Hi, everyone. Happy Sunday morning. Today, we're going to be covering unknowns from the last 3 weeks. I hope everyone had a nice Thanksgiving. We are going to go ahead and get started. We're covering 3 chapters this weekend, so we're going to get through some unknowns. If you have any questions, please feel free afterwards to send an email. If you have any comments or suggestions or anything that you'd like to add, we welcome your feedback, so please let us know, again, if you have any questions or feedback. Without further ado, we'll go ahead and get into the cases for this week. Today, we're going to be reviewing unknowns from the last 3 chapters that we've covered. So we're going to be going over degenerative diseases, nutritional disorders, and some metabolic conditions. So we're going to start off with a few unknowns from each of those chapters. So we'll be beginning with a few cases from chapter 10. So to start off here, we've got a shave biopsy, and you can notice right away that the epidermis is relatively unremarkable. And looking at where we are on the body, this looks to be an acral surface. So we've got nice compact hyperorthokeratosis, and this looks to be relatively non-sun damaged skin, with the action here being in the dermis. So we've got a palisaded granulomatous infiltrate with some alteration of the collagen. So we've got normal collagen at the periphery, and then centrally, we have these areas of basophilic collagen with necrobiosis. So the collagen is blue and it's altered. And if we go up to higher power, you can see that there are these spaces within the collagen, along with these little areas here that are neutrophils. So we've got these segmented nuclei and then some fragmented bits of neutrophils, along with this sort of palisaded arrangement of histiocytes surrounding the bluish material here. So this is a histiocytic infiltrate surrounding basophilic degeneration of collagen with a few neutrophils, with a smattering of lymphocytes surrounding this area. So this looks pretty good for GA on an acral surface. And then we have a PAS stain here that goes along with this. Now our differential diagnosis here, oh, sorry, this is actually a colloidal iron, so not a PAS stain. So here we've got blue, and this is highlighting some of the mucin that we could see. So if you were suspecting some bluish mucin, here we have histologic confirmation that there's some mucin within those central areas of necrobiosis. So that is a necrobiotic pattern of granuloma annulare. And now we have a punch biopsy, and we've moved to a non-acral surface. So you can see the epidermis looks a bit different here, so much less of a thick stratum corneum. Here we've got basket weave stratum corneum and a pretty normal epidermis, very minimal spongiosis. And then within the dermis from low power, we get a sense of some busyness in the dermis. So you can see from here, there's a little bit of blue at the periphery, a little bit of hypercellular blue inflammation at one edge here. And then at another edge over here, there's a little bit of a sense of a busy dermis. So there's some blue cell infiltrate. So we can go in a little closer here. And then you can get a sense that there's some interstitial blue cells here. And then maybe you could get a sense that there's some blue to the collagen. So here it's very pink. And then there's a bit of pallor or a little bit of extra space in the dermis and a bit of a blue cell infiltrate here. So if we go up to higher power, you can see that there are some histiocytes kind of palisading and intercalating between these collagen bundles. And then again, we've got this beaded blue material here. So you can see these little blue dots and blue specks. That's mucin kind of splaying these collagen bundles and pushing them apart. And then we've got histiocytes, so a few multinucleate cells and histiocytes wrapping around these collagen bundles. So this is more of an interstitial pattern of GA. And then again, here we've got our colloidal iron stain. So if you were wondering if maybe that was some beaded mucin, here we have that nice blue mucin as confirmed by the colloidal iron stain. So this is more of an interstitial pattern of GA. Your differential here might be interstitial morphia. So that would have not really the mucin, but you might see a few plasma cells. You could also maybe wonder about breast cancer. If you saw some atypia, you could think maybe of leukemia or lymphoma might be something you wouldn't want to miss. If this were a digit, you could think maybe of epithelioid sarcoma if there was atypia. So just some things to think of in your differential diagnosis. But in this chapter, it's interstitial GA. You might also wonder about an interstitial granulomatous drug eruption, interstitial mycosis fungoides if there was atypia. And then sometimes in this perivascular infiltrate, you might be able to find an eosinophil or two. If you start seeing more plasma cells, then you might wonder about a tick bite. or again, early interstitial morphia. But here this is GA, and then biopsy C. Now we have a slightly different pattern. So we can see we have another punch biopsy. And here in the epidermis, there's some very slight spongiosis and mild compact hyperorthokeratosis. We are perhaps somewhere near the face because we've got some more prominent sebaceous glands. This might be a slightly older patient because we also have some solar elastosis. And then within the dermis, we have collections of histiocytes. And in this case, they're forming little balls or little epithelioid collections. So they look similar to the epithelium above. So these are epithelioid collections of histiocytes. And the lymphocytes are respecting these little epithelioid collections. They're surrounding the epithelioid collections of histiocytes. And this arrangement is more of a sarcoidal arrangement of epithelioid histiocytes. So when the lymphocytes are surrounding the histiocytes, but not really intermingling with them, this is a sarcoidal arrangement. And we tend to see that with sarcoidosis. We can also see that with infectious processes. So this would be one that you'd want to get some stains with. But this pattern is suspicious for sarcoidosis. A diagnosis of exclusion, always want to polarize these to look for any sort of foreign material. But this is a pattern of sarcoidal inflammation. And then here within this giant cell, this almost looks like it's trying to make a little asteroid body. So you can see there's a little pink kind of stellate figure here within this giant cell, looking like it's trying to be a little asteroid body here. But this might be a little lesion, perhaps of lupus pernio, if it were from the nose. But a nice example of sarcoidal inflammation. And then for part D, moving on, we have a shave biopsy. And then similar to our previous biopsy from low power, we can see that this looks very pale. So we've got normal epidermis, normal collagen at the periphery, but then in the center, we've got collections of epithelioid histiocytes, so very pale staining compared to the normal dermis. This looks like perhaps a younger patient, so not much in the way of solar elastosis. It's hard to tell where we are on the body, but perhaps an extremity because we're not seeing a lot of sebaceous glands. But here we have collections of epithelioid histiocytes abutting the epidermis and forming collections of giant cells. And here there's not much in the way of an admixture of lymphocytes or neutrophils. Here it's mostly these sarcoidal collections of histiocytes and then foreign body giant cells with this peripheral rim here of cleared out cytoplasm. But what really catches your eye here are these structures. So we've got all of these kind of pink to pale staining circular structures within the giant cells. So lots and lots of these pink kind of foreign looking bodies here. And we can take our little measuring tool here and take a little measurement. And there may be about 6 micrometers across, but you can see once you find one, you start seeing lots of these little circular thingies here, foreign buggers here within all of these giant cells. So lots and lots of these little oval bodies here within these giant cells. So these do not belong. These are not native to the body. So we've got a sarcoidal inflammatory response here with many, many of these pale staining circular structures. And our next stain here is a PAS stain. And we can tell it's a PAS stain because we have our control tissue here. So we have nice dermatophyte control tissue. And here is our granulomatous infiltrate. And all of those little circular structures here are PAS positive structures. So this is probably either crypto or histo, probably a little bit, not really seeing like broad-based budding for blasto, but this is a cutaneous fungal infection, deep fungal infection, and if it didn't respond to appropriate therapy, you might want to get a tissue culture to see what exactly this is. And I don't remember off the top of my head what this patient had, but this is the reason why whenever we see a sarcoidal pattern of inflammation, we get stains to exclude an infectious process, and why sarcoidosis is always a diagnosis of exclusion, why you always want to look at high power and make sure that you don't see any sort of bugs in there. And then also just to add on for sporotrichosis, typically that's a condition where you would see very few organisms. So because we're seeing so many organisms here, this is less likely to be sporotrichosis. Typically, if you find any organisms in the biopsy, they're usually very few in number. So for sporo, it would be unusual to see this many organisms in the biopsy, although I guess you technically could. It's kind of more unusual for that. Moving on to unknown E. So now we have another punch biopsy. And again, this looks like another relatively young patient, healthy collagen here, not a lot in the way of sun damage. And here we see some nice erector pili muscles. And then the other thing that catches our eye from low power is this black stuff. So we've got lots of tattoo pigment, so lots of black foreign pigments in here. And then looking in the other half of the punch, we see something else that doesn't belong. So quite a bit of inflammation in the dermis. And again, we have collections of histiocytes here. And in contrast to our previous sample where we saw quite a bit of little circular structures that didn't belong, here we see an eosinophil and then a few more eosinophils and a neutrophil or two. So this one we'd want to get some bug stain to make sure that there wasn't a contaminated tattoo needle that introduced some sort of infectious process with it. But depending on the clinical history and how long-standing this is, you can sometimes see atypical mycobacterial infections, especially if someone has a new tattoo. This one can be kind of hard to tell, but doesn't necessarily look super fresh. But they've got some scaling here and some erythema. I would suspect this may be more of a granulomatous tattoo reaction, which are more common with the red inks. Even with black ink, oftentimes there's some red mixed into it, and you can't tell histologically the color of the ink, but red is usually the biggest offender as far as allergic reactions or granulomatous reactions, but important to get bug stains and exclude any sort of infection. There are some newts and eos in here, so that's usually something we'd stain up and make sure that we don't see anything more concerning. A kind of a sarcoidal tattoo reaction. And moving on to F. Here we've got a shave biopsy, and we are somewhere that is very rich in eccrine coils. So here you can see we've got a lot of eccrine coils within the dermis. And again, we're back to what we saw in part A, some thicker hyperkeratosis. We've got a stratum lucidum, so we're somewhere acral or near acral. And then we've got palisaded collections of necrobiotic material. And in contrast to what we saw in part A, here these granulomas are very pink. So in part A, around the areas of necrobiosis, they looked much more blue in the center. And here in the center, we're seeing much more of a pink infiltrate, surrounded by some fibrosis, and then again, collections of epithelioid histiocytes. So in contrast, we've got blue granulomas for the previous one, and now we've got very pink granulomas. So this is an example of a rheumatoid nodule. You can also sometimes see pseudorheumatoid nodules. And then the differential diagnosis here would be deep GA, but this is an example of rheumatoid arthritis or rheumatoid nodules. Clinical history is helpful here. And then this is colloidal iron stain. And you can see here that in these areas of necrobiosis, we're not picking up a lot of mucin. There's maybe a little teeny tiny bit of mucin, but in contrast to GA, that'll really light up with lots and lots of mucin. And here we're seeing just very scant mucin. But again, clinical history is important to differentiate those two. All right, we made it through our first chapter. So moving on to the second chapter of rapid fire unknowns. I think I'm going to go backwards through these ones. So starting here, we have a punch biopsy. And here we have maybe a younger patient. So we have very small adnexa. So we have a tiny hair follicle, and we have very diminutive adnexal structures, so little tiny hairs, little tiny glands. So this is probably a younger patient, not much in the way of solar elastosis. There's some edema in the dermis and some very slight spongiosis in the epidermis. So you can see that there's some spaces here in the epidermis. There's some scale, so perikeratosis and spongiosis. And then there are also some necrotic keratinocytes. So there's a little dead keratinocyte here. There's a Langerhans cell in the epidermis. This little guy here is a Langerhans cell. And then as we cruise along, there are some extravasated erythrocytes. So we've got some red cells coming out here. Again, as we move along, there are a few dyskeratotic cells, but not many. And then here are a few siderophages. So you can see this brownish yellow material here is the result of red cells that have leaked out of the vessels and then broken down. So this may have been going on for a little while, long enough for some red cells to degenerate. And then here again, we've got another dyskeratotic keratinocyte, but we don't have any basement membrane thickening. We don't have mucin in the dermis. We've got some edema. There's a very sparse perivascular infiltrate, but there's no real deep inflammation. And then as far as the composition of the inflammatory infiltrate, this appears to be prominently lymphocytic, maybe a histiocyte or two, but not frequent eosinophils, not many neutrophils. The vessels, despite being a little bit leaky, look intact. There's no fibrin, there's no fibrinoid necrosis, and there's no leukocytoclasis. Here, there's a little bit of perikeratosis and some scale, and then some slight edema. So this is kind of a non-specific pattern where a clinical history would be helpful. In this case, this is a patient who had a symmetric flexural eruption of sudden onset. It's a younger patient who developed an exanthem starting after being a little sick with a sore throat that started on the elbows and knees and then spread pretty rapidly, but was feeling otherwise fine, and the rash wasn't really bothering them too much. So this is an example of Giannotti crosty. So often what you'll see is some spongiosis, a little bit of scale, papillary dermal edema, some mild erythrocyte extravasation, and then a perivascular infiltrate. This can look similar maybe to psoriasis. You might wonder about just other common spongiotic dermatitis like eczema. Typically, eczema won't have the red cell extravasation or this very subtle interface dermatitis. So the presence of those scattered dyskeratotic cells and the red cells coming out here speaks more to a viral exanthem. This could just be an ordinary viral exanthem. The scale might make you wonder a little bit about psoriasis in some of these areas, or even pityriasis rosea might have some similar features. And typically pityriasis rosea would also have maybe a little bit more of, a little bit less edema. But this could be maybe the Herald's patch of pityriasis rosea. It's really the clinical information is helpful here because it's a similar demographic and they're both viral exanthems. But I think that would be kind of your main differential diagnosis. And then eczema, you might see an eosinophil or two. You shouldn't really see the interface changes. Psoriasis, you should see some neutrophils. Pityriasis lichenoides, you should see some more interface and perhaps a neutrophil or two. Lymphomatoid papulosis, you should see some more lymphoid atypia. And then there are some perhaps activated lymphocytes. So if you see all of these lymphs coming up into the epidermis, you might worry maybe about MF or some sort of atypical process, but there's really quite a bit of epidermal spongiosis here, and this is really an acute process. So even if you see a big lymphocyte or two, this is not an atypical process, and it's not anything bad or scary. So this is an example of Giannotti crosty. And then we're just going to skip over this one because I don't think it's the greatest example of this entity. We're going to go to part E. And here we have a punch biopsy. And this is from a younger patient. And in this half of the punch, we can see that there is a collection of neutrophils within the epidermis and in the subcorneal space. And directly beneath that, in a vertical configuration, we see a few histiocytes and then some more neutrophils. And beneath that is a hair follicle. In the other half of the punch biopsy, there is separative inflammation. So we have some neutrophils and some histiocytes, and then some more neutrophils. Again, kind of connecting, if you could use your imagination, all in a vertical configuration. So this was a patient, here again, a few newts, and then even extending down here into the dermal subcutaneous interface with some neutrophils and histiocytes, and spilling a little bit into the panniculus, into the lobule here with some inflammation. This was a patient with painful subcutaneous nodules that were ulcerating and then leaving behind undermined sores that were taking quite a long time to heal, also with oral apathy and developing violaceous undermined lesions who also had pathergy. So wherever they had an area of trauma, they were developing painful blisters. And this was a biopsy of a pustule. So this patient had what was consistent with Behçet's disease. And here you can see kind of like a neutrophilic pustule. This was a younger patient again, so you can see like a small adnexa, not much in the way of sun damage. And if you didn't have that clinical history, this would just look like a separative folliculitis. So you could imagine with these neutrophils kind of in a vertical column here, that's kind of your clue to a separative folliculitis. If you had no clinical history, I think you would just call this a separative folliculitis. But we think that a lot of these neutrophilic dermatitis arise in association perhaps with a follicle. And I think maybe you could hallucinate that a little bit here. Important to get antimicrobial stains, a PAS, a Gram stain. And depending on the clinical context, you may want to look for AFB. But I guess with no clinical history, this could just be a separative folliculitis. But in this case, this was suspected to be Behçet's. It could also be other neutrophilic dermatoses like pyoderma gangrenosum. This is the next case, part D. And then here I think, again, illustrating kind of a nice example. So here we have a punch biopsy, and here we have almost a pseudocarcinomatous epidermal hyperplasia. So there's spongiosis, some neutrophils within the stratum corneum here, and neutrophilic transepidermal migration with serous scale crust, epidermal spongiosis. And then we have this reactive proliferation of the epidermis with quite a bit of pallor and a downgrowth or downward proliferation of the epidermis. But you can see that the keratinocytes are quite large, and compared to how large the keratinocytes are, the nuclei are actually quite small. So even though the epi is proliferating downward, the cells are small and they're relatively uniform. So this is a nice example of pseudocarcinomatous epidermal hyperplasia that we can see in the setting of inflammatory processes. And here we're on the lower leg, and I think you can get a sense of that with this lobular proliferation of the capillary vasculature. So we have these small vessels arranged in these little kind of cannonball proliferations. And there's a background of hemosiderin and erythrocyte extravasation. And these are the types of changes that we tend to see in chronic stasis. So you get fibrosis, you might even see some mucin, all this hemosiderin, fibrosis. This patient has very long-standing stasis. In the background here, you can see some thickening of this medium-sized vessel. So these are all very chronic stasis type changes. And then in the midst of this reactive proliferation of the epidermis, we've got separative inflammation. So we have collections of neutrophils and then all this breakdown of neutrophils. So some dust and chalasis and little pieces of neutrophils, but no real bacteria, no creatures like we saw in our earlier biopsy. Again, here, more really dramatic stasis changes. These can be difficult to interpret, though, especially in a partial biopsy or if someone was looking for a Ka. These can definitely be challenging because you can see these interanastomosing cords of epithelium. And, you know, if you were to zoom in just on some of these cells, some of them look pretty scary. Like if you took a picture just of that cell, it looks kind of spooky. So context and history are definitely important here. But this was a patient with a history of stasis and a violaceous bordered ulcer with a clinical photo that was pretty consistent with pyoderma gangrenosum, not healing, not responding to therapy, and their clinical differential was PG versus a stasis ulcer. And with the intraepidermal collections of neutrophils here and a biopsy at the violaceous undermined ulcer border, this is consistent with PG. But it can be tricky because the background changes definitely look like stasis. This is all stasis, all of this stuff. But these areas with the neutrophils are good for pyoderma gangrenosum. So sampling is really important. And in some patients, it may be necessary to take more than one biopsy before you get a good diagnosis. So with these patients, I think it's really important to counsel them before you take a biopsy that you might need to take one or two samples. Clinical history is also really helpful. So you want to make sure that you're giving your pathologist the information that they need to make a diagnosis. A picture and even just a very short history can be super helpful in these cases. So if you get something that you don't think fits, it's also really helpful to just pick up the phone and, take another look here, because you could imagine that if this weren't bisected, it might be easy to miss the diagnostic area in this biopsy. So nice example of PG. And then this case is fantastic. So this is one that we just had recently. And this one I think is an easier diagnosis compared to the last one. So the last one is a little bit more subtle, and the histologic findings you had to hunt for a little bit in the background, but this one is more straightforward. So here there's a little epidermal spongiosis, and you can see right away that there are some neutrophils, but the main action here is in the dermis and in the mid to deep reticular dermis. And right away you notice that there is a collection here of suppurative inflammation. So quite the predominant cell type here is neutrophils. So lots and lots of neutrophils, lots of degenerated neutrophils. So this is really kind of almost an abscess or a suppurative dermal inflammatory infiltrate. And again, here you can maybe see that there might be some sort of a remnant of a follicle or something surrounding this. So maybe it originated from a follicle. But this was a patient who was suspected to have pyoderma gangrenosum. And in that context, this biopsy is consistent with pyoderma gangrenosum. For these patients, it's often important to biopsy for tissue culture at the time of diagnosis, because the main differential here would be an infectious etiology, and obviously the treatment is very different. So whenever you're biopsying for sweets or a neutrophilic dermatosis, while the patient's numb, while you have your punch, while you're at the bedside, go ahead and get that tissue culture and send that off. We can stain for microorganisms, but those special stains that we do are notoriously insensitive and can miss quite a lot. So tissue culture is much more sensitive, much more diagnostic. So always get that fresh sample and send it off for tissue culture whenever you can, especially if a neutrophilic dermatosis is in your differential diagnosis. So nice example of pyoderma gangrenosum. And then just another example here, neutrophilic dermatosis. This one we don't really see the follicle, but a predominantly neutrophilic dermal infiltrate. Not much in the way of papillary dermal edema here. If you start seeing more papillary dermal edema, you could think of sweets, but I think that would be not so much in the differential for this one. But neutrophilic dermatosis compatible with pyoderma gangrenosum. And I think this is more typical for the type of biopsies that we see when people are biopsying for PG, would be this type of infiltrate. And then sweets, often more papillary dermal edema, more of a diffuse neutrophilic infiltrate, and more maybe dermal hemorrhage as compared to PG, which tends to be more discrete within the dermis. And then the next case, I'm sure if you saw the recent lecture for this, this one might be familiar for you, but this is a fantastic case, which in my years, I've only seen one other clinical case of, and this is just a fantastic case. So this is a biopsy from a flexural area. And I think what's striking from low power is the epidermal hyperplasia and epidermal spongiosis with vesicle formation. So the epidermis is quite a bit thicker than normal. So you've got epidermal hyperplasia. And then you can see from low power that there's a lot of fluid or some other material within the epidermis. So all of these clear spaces. And then there's also quite a bit of vascular ectasia and pallor in the papillary dermis. So we are in a near mucosal surface because there's not really a granular layer here. And there are spongiotic vesicles within the epithelium. And within those vesicles are numerous eosinophils and a few neutrophils and also scattered lymphocytes. And then this vascular ectasia. And then within the dermis, there are also numerous eosinophils. And if we cruise along, I don't really see great acantholysis. There's maybe Some suggestion here of some suprabasilar acantholysis, but most of what we're seeing is spongiosis. I think over here, maybe there's some acantholysis. So most of what we're seeing is spongiosis within the epidermis. There's maybe a little bit of suprabasilar clefting here, but I think you'd have to know the clinical history and do some hallucination after the fact to imagine that. But this is a fantastic case of a patient with ulcerative colitis, so a known history of inflammatory bowel disease, and these intertriginous denuded lesions who presented with suspected hyostomatitis vegetans. And that's not something that you see come in very often on a requisition. And I just have to give huge props to this dermatologist because, it's a very rare variant of pemphigus, and to see someone who just totally nailed it, I thought was awesome. So you guys are super lucky because in, I don't know, however many, I don't want to admit how many years I've been practicing, but it's really uncommon to see this. And this is just perfect histology and a perfect biopsy. And we're really lucky to have it in our study set. But what we'll see histologically is hyperplasia of the epidermis with eosinophils and eosinophilic spongiosis, often with pustule formation, and rarely you'll see a little bit of acantholysis. And with DIF, you'll see typical findings of pemphigus, so intracellular deposition of IgG, typically presenting in patients with inflammatory bowel disease and most commonly with ulcerative colitis. So a really, really cool case, usually in flexural or intertriginous areas, perhaps due to friction. We're not really sure what the pathogenesis is, but here you can see like these nice little abscesses composed of eosinophils. So just beautiful case, beautiful histology. Kind of burn this into your brain because this is just gorgeous and very, very rare. So you're lucky to be able to see one of those. All right, and the next is another super cool case. This one again, so kind of going back to what we saw before, is a punch biopsy, and we can tell that we may be on the lower leg because we have a little fibrosis and perhaps, again, some lobular reduplication of the capillary vasculature, not as dramatic as what we saw before. Here it's a little bit more limited to the papillary dermis. But what's striking here is the pallor of the epidermis and then the scale across the epidermis. So we have pretty regular psoriasiform epidermal hyperplasia. And then the normal color of the epidermis would be maybe more over here where it's a little bit spared around the acrosyringium. But the remaining epidermis is very pale. So we have epidermal dysmaturation where the epidermis is expanded and then uniformly kind of lighter pinky blue than it's supposed to be. And the granular layer is diminished. So where we should normally have the granular layer here, it's a little bit more pale than it should be. And then in these areas of perikeratosis, we also have little collections of neutrophils and some spongiosis within the scale. And then oftentimes there's more of like a sharp demarcation or sharper area of pallor. This one doesn't have that wonderfully, but you can see lots and lots of newts within the scale. And then some dilated vasculature. The suprapapillary plates are relatively intact as far as their thickness. Some of them are a little bit thinned. And then there's some vascular ectasia here. If we cruise along, you can see that there are maybe a few dyskeratotic cells, but not really interface changes. And then not a lot of suprabasilar mitotic figures. And then within the dermis, the inflammatory infiltrate is mostly lymphocytes. We're not seeing a lot of plasma cells or eosinophils, but just kind of like big epithelial cells that are not maturing normally. So this is a patient with a history of hepatitis C who was on ribavirin and kind of malnourished, who presented with progressive erythematous plaques that began on his toes and were expanding up his lower extremities, and was treated as a cutaneous fungal infection because it started on his feet but hadn't responded to therapy. And for the most part, they were asymptomatic, but didn't seem to be improving. So he was referred to dermatology. And a few of the lesions had kind of a central area that looked a little bit dusky, and a couple of them had what almost looked like a little vesicle or pustule at the periphery. And a PAS stain was negative for fungi, always very important on the lower extremity to exclude a fungal infection, especially because this started on the digits. So not a fungus, but a psoriasiform dermatitis. And this is an example of necrolytic acral erythema, which is commonly associated with hepatitis, especially hepatitis C. But you can also see it in patients who don't have hepatitis, and it's more commonly associated with a zinc deficiency, and patients do respond to supplementation with zinc. They also tend to respond well to steroid therapy. So he did very well with zinc and topical steroid. And then for that last case, for differential diagnosis for necrolytic acral erythema, the other necrolytic erythemas would have a similar histology, but obviously the clinical would be different. So necrolytic migratory erythema with glucagonoma, pellagra would have a similar histology, but a different clinical. So clinical pathologic correlation is important there. And then psoriasis has a similar histologic appearance, slightly different. So they all look kind of similar, but I think the epidermal pallor that you see in the upper spinous layer, more typical for those necrolytic erythemas, but it's not always perfect and it doesn't always read the textbook. And in the cases that I've seen, it tends to look more psoriasiform and not as pale as what you see in the books. So that was for the last case. And then moving on to chapter 12. So for our metabolic syndromes, this is always a cute one. So just gorgeous histology. So here we see acral surface again, where we've returned to the acral hyperkeratosis. And we can see that the epidermis has become detached from the dermis and relatively little in the way of inflammation. We've gotten back to the older skin here. So there's quite a bit of solar elastosis. And in the epidermis, it looks relatively unexciting. I would say there's maybe a couple of dyskeratotic cells. I don't know if I could hallucinate a caterpillar or two. I don't know if I could convince you that maybe there's like a caterpillar head or a caterpillar body, like these little guys here. Like maybe you could hallucinate like a little squiggly guy there. I don't know. I could imagine one. Maybe like right here, like a little swirly caterpillar there. All right, and then this is kind of where more of the action is. So if we move to the dermis here, we've got dermal papillae just kind of sticking up into the empty space here. And as far as the inflammatory infiltrate, this is what we call cell pore. So we have a cell pore subepidermal blister. We do not see much in the way of neutrophils or eosinophils. And in an acral area in an older patient, this would most likely be either porphyria cutanea tarda or pseudoporphyria. And one thing that's often helpful for this diagnosis is to get a PAS stain. And what you can look for is what we call tram tracking of the basement membrane zone. So if you were to look at the blood vessels in the dermal papillae, what you want to look for is reduplication of the basement membrane zone. And it can be kind of hard to see here with the Phillips, but again, you have to use your imagination a little bit. But what you're looking for is kind of a double line or a little train track of reduplication of the basement membrane material. And I always have to use my imagination hat. So if you don't really see it and you kind of have to pretend, you are not alone. But what you're looking for is like two little lines, almost like what you would see clinically with a coronoid lamella around a porokeratosis. So like two little lines around the blood vessel, but I think you can kind of see it here. Like one little line there and then another little line here is what you would typically see with PCT. So this is just a gorgeous example of porphyria. And then clinic or histologically, we can't tell PCT from pseudo PCT. So you really need a clinical to differentiate the two. All right, and then this is just a nice example of a nevus. And then within the nevus is this little blob. And the reason that this is in here is because the pigment here is your clue for looking for amyloid. So this is a polypoid nevus that's been kind of flapping in the breeze. And with the friction, you get degeneration of keratinocytes. And when the keratinocytes die, they spill not only the keratin contents creating amyloid, but they'll also spill some of the melanin pigment. And when they spill the melanin pigment, that's your clue histologically for lichen amyloidosis or macular amyloidosis. And that's in our differential diagnoses of invisible dermatoses. So it's one of those things that is so easy to miss, which is why they love to put it on your boards. It's something that's hard to find. So remember pigment when you look at a punch or when you see something on a test and you're like, oh my God, I don't see anything, or oh my goodness, I don't see anything. Remember to look for pigment in the papillary dermis, and that will be your clue to find amyloid. So pigment is your friend when looking for invisible dermatoses. So with that in mind, let's take a peek at this little guy. So here we have some scale, which is helpful. It's not so invisible, but this is likely a darker skin patient. So you can see that there's some background pigment here, and they have been rubbing and scratching at their skin. So this is not an acral surface, but we have maybe like a hairy palm sign. So we've got a stratum lucidum in skin that has hair follicles. So this has been lichenified. This patient has been rubbing and scratching and picking at their skin, which is also evident by this area of hyperkeratosis and hemorrhage and serum within the stratum corneum. So there's been rubbing and scratching going on here. We also have some dyskeratotic cells here. So this patient, again, has been rubbing and scratching at their skin. And to show further evidence of the rubbing and scratching at their skin, we have some separation here. So dermal epidermal separation, you can see blister over scar as an artifact of processing of tissue. So this separation here is not from porphyria, but is just artifactual from tissue processing. And it's because we've got all of this amyloid. So you can see that there's kind of a different character, or this fluffy pink character in the papillary dermis here that's slightly different in color to the striated collagen. So you can see the collagen has these little lines in it. And in contrast, this material here in the papillary dermis is pink and amorphous and just more of a bubblegum color in contrast to the brighter pink of the collagen. So this is keratin amyloid. All this blobby stuff up here that just looks pink and amorphous is from dead keratinocytes. So this patient has rubbed and scratched at their skin so much here. These keratinocytes have died, and some of them have come out this way, and some of them have been kind of spit out into the dermis. And this is an example of amyloidosis. So this is more of kind of a like an amyloidosis because it's maybe a little bit of a thicker lesion. And then here again, you can see very subtle collections here of amyloid material right beneath the epidermis. So these keratinocytes are being destroyed and kind of like spilling their guts right underneath here. And again, you can see there's some subtle pigment that's being picked up by some of these macrophages in the superficial dermis. And your clue from low power is some of that pigment that's being spilled out, but it can be really subtle. So this one, you're helped out by the epidermal change. And this one, they were looking for a primary dermatitis, but most of these changes here are from lichenification. So sometimes you might be able to find an eosinophil or some suggestion that this patient may have a background of eczema or psoriasis or some other condition that's leading them to rub or scratch at their skin. You want to make sure that these patients don't have a dermatophyte infection or some other reason to be pruritic. Okay, but in this example, we don't really see a primary dermatitis. We just see a stratum lucidum. Okay, and then our last case here, this is one example of like the invisible dermatosis. So from low power, we see a punch biopsy and we see an epidermis and a dermis that looks pretty normal. This may be from the back because the dermis looks relatively thick. And then we see that there's some subcutaneous fat here. We see a little hair follicle. We see some eccrine coils. This looks, again, like maybe it's from a young or middle-aged person. There's sebaceous lobules. There's a normal epidermis. There's an intact stratum corneum. There doesn't seem to be too much in the way of any sort of alteration. So we're kind of in our null differential here. So the stratum corneum looks relatively normal. I don't see any fungal forms. The epidermis, we start to see maybe some little signs that there's something going on here. So there's a dyskeratotic cell here. There's another dyskeratotic cell here. And then here we see some pigment. And then remember our friends we saw before that looked a little bit different as far as the pink. So here we see the normal papillary dermal collagen. And then over here, do you see these subtle pink blobs? So these little pink blobs, again, are dyskeratotic keratinocytes that have kind of spilled their guts here. So this is papillary dermal amyloid. And then once we see a little bit of it, if you continue on, now here's another little collection of it. And then if we move over here, there's a little bit more here, there's another little bit here, and it all tends to be concentrated in the papillary dermis. So this is all from rubbing and scratching. And this is in an area with hair follicles. So I would venture to say we're not on the leg, we're probably on the back. So this is probably an example. Okay, sorry, I just had to look it up and see. So this is from the left upper back. So this is an example of like an amyloidosis. So just chronic rubbing and scratching with this amyloid material. And again, the clue here is the pigment. So from low power, it's difficult to see, but once you zoom into kind of medium power, you can get a sense for the pigment in the papillary dermis, and that's your clue to go up a little higher and look for the pink blobs. And then the necrotic keratinocytes here are from the rubbing and the scratching. You might be able to see maybe some changes, just keratotic cells, say from erythema ab igni, but usually you wouldn't see the amyloid changes, and you might see a little dysmaturation or telangiectasia with erythema ab igni, but typically you wouldn't see this amyloid material with that. So that might be in your differential diagnosis, but beautiful example of like an amyloidosis. So that is all I have for you guys. If you have any questions, please feel free to email us or contact us. And I hope you enjoy the rest of your holiday weekend and that you're liking these lectures. If you have feedback or questions or things that you'd like to see more or less of, please let us know. And we look forward to seeing you back soon. Take care.